from Allied Health who have come numerous occasions to do event training with us as well. We have purchased a brand new Allied Health vent, nice new vent. All our equipment is purchased. We have pumps, transport pumps, and so we have our equipment there. We have it. Everyone's been trained on it. Those 10 paramedics have been trained on it. Right now we're using it at paramedic level care. We have a specialty truck set aside with the vent mounted inside of it and all the equipment associated with it. We have some difficult airway kits, although right now we are not MFI. We have some video laryngoscopes that have been put into service, as well as some video stylettes for difficult airway intubations. And the medics have been trained on those as well. So right now, everything has been certified to Dr. Glenn's satisfaction as far as our level of training that's been done. And he is signing off right now individually on medics. It's an individual thing of what he feels comfortable with. He looks at their trainings that he's signing off on them. We're expected to have about at least 9 or so or 10 signed off by the end of the day today as getting Dr. Glenn's seal of approval for the critical care transports. And then we're looking at going an online time of Friday morning at 07 as far as being able to have that capacity in motion.
So what has Dr. Glenn's involvement been in the training process, and what contact has he had with the paramedics?
He's been looking over our curriculum, the type of material that's being utilized. He's been looking over how many hours in each category. He's looking over the people that have been doing it. And you know, he's a busy man, but we've been catching him here, in his office. So he's been kept up front the whole way about what is being taught in what category, airway, respiratory, cardiac, throughout the whole process. As far as whether he's been doing teaching himself, he is not, as long as we've provided that information that these are people that we're not just dragging them off the street. We've informed that respiratory therapy from Nathan Lutheran Hospital has come over to do some training. We told him that Allied Health is doing some training, and he was fine with that.
What is Allied Health?
They're the manufacturer of the vent.
How are your didactics being accomplished? Is this an online program, or is this another medic teaching another medic, or?
We're doing it a hybrid. A lot of the didactic material is being taught through delivered online with strict tests where you have to maintain it's timed. It's essentially no different than sitting in front of a PowerPoint presentation or in a classroom. You have to make sure that you're physically in front of it, that you're responding to the lectures, to the seminars, that it's an interactive material. It's not just you turn it on and you walk away and you go take a nap. It's no different than going into a classroom, and we're using a platform that has been approved. The state of New York has actually approved it for online recertification through CenterLearn, provided that we provide our training material to them. But the state of New York has enough confidence that they've approved it for. You can use it for 100% recertification through your paramedic.
So your initial didactics are CenterLearn?
Your initial didactics are CenterLearn combined with other individuals, respiratory therapy, the manufacturers, CICs as well, delivering classroom material.
So there's not a formal, is there a formal education center, or is it a great review?
No, it's a formal education center. Again, it's the classes that are set up are essentially, cardiology 101, and it's no different than going through a cardiology class. but the way they're being delivered is a hybrid delivery. It's being delivered instead of going to that classroom and sitting in the classroom watching the material being presented. It's being presented. We have a lot of people trying to get paramedics together in a group is like herding cats. You're never going to have everyone being able to get together to combine. Also due to operational capabilities. So we have people who have to do this stuff on duty as well. So we chose to deliver it in an alternate way.
We have in the room this morning one agency that has been previously approved after rigorous lengthy training for their SCT, and that's CMT. GAVAC is of course approved for it, but we don't have Tom here or Mickey this morning, they're excused. Could I ask Beth, does the training modalities that Fulton County is following seem to be in line with what you have experienced?
Yes, and the only thing that really, that I would add in the future, but you can't because you're at ground zero, would be some sort of ride-along with already established SCT.
We do. We have that in place because that was the question that we were looking at, and the continuity of it. We can't really do an internship program when we don't have a program established. So we do have policies and procedures set in where how once it's instituted, how it continues on down the road, and one of the ways that it continues down the road is that, look, these people that they've got to approach the director of operations, say, I want to be with the specialty care transport. They've got to be in good standing. They have to be paramedic, for at least a year to begin their internship program. Then they enter the program, and then they're assigned, just like if you're doing a paramedic internship. So there's certain levels that they have to meet. In addition to doing their program, they have to intern underneath another already established veteran medic. So they're not just being handed a vent and a pump and being...
Yeah, and I find the intubated runs to be the most challenging. Aren't they, B? We brought one in the other night who had an arterial bleed from a tonsillectomy that they had intubated to protect the airway, and it was just, it took quite a bit of management, and those are the ones that we have our paramedics do, depending on how well they perform, up to 5 of those before we clear them. It's just, that's our highest acuity, least stable patient.
Yeah. And again, like it depends on again, it's approved 1-to-1 by Dr. Glenn, and whether he says, okay, I feel comfortable. It's his comfort level. Okay, I feel comfortable with saying that you can perform at this level, but somebody else, I want you to do more time as well. So we do have plans in place once the program is established for the internships
and you're doing 100% CQI on the PCRs of...
Yes,
yeah.
100% is going to the QAQI.
And that's, you're pretty much mirroring exactly what we're doing now.
Yeah, we have the RE-PCR program. We'll flag all the transports and automatically push them over to QA. And then as a backup, we have our ping forms that they fill out for paper tracking in case the system itself has a failure.
Tom, are you guys approved to use Senator for 100%?
We had the paperwork to complete it. We've not completed it for 100% for New York State yet. We had quite a few things on our plate that we were working on. But we do have the paperwork from St. Laurent that we have to submit to the state here, shortly. Just because these paramedics are doing it, or it would actually be more than 96 hours by the time they complete a little lap time, whatnot. Part of the incentive is that they can potentially use that for their CME for research. Whereas right now it's only half that they're allowed.
Tom,
how many hours?
I'm sorry.
What's that?
How many hours total do they put in for their classes?
For the CT classes?
When they do the training, okay, it's on the videos, and stuff. What's the total hours they
It's-
have?
it's a
for the
total
whole
out-
class?
didactic
I'm an SCT medic for GABAC.
Yep.
Okay. We were 13 weeks.
SCT, the amount of hours is 96 hours, according to the University of Maryland guidelines.
And what are you guys accomplishing? Is it the 96 hours?
Yes, the 96 hours, whether you take the 96 hours and you stretch it out into 13 weeks, or whether you stretch it out into 6 months, or, we're looking at hours, not,
Days a
we could,
week.
we could send people to the University of Baltimore, and within 2 weeks, they could come back completed with the amount of hours and the curriculum. We're looking at how many hours of each category you actually trained in. So it's a total of 96 hours,
So if they
and
went
it's
to,
broken down.
if they went to Baltimore, would they get physical contact with patients on ventilators?
Towards the end, the lab time, but as far as the classroom training is essentially, it's 96 hours of classroom training.
Tom, what do you see as the next step now in implementing your program?
Well, other than the 100% QA/QI, there's a lot of variables we need to track how the truck is being utilized, any deficiencies that may arise. When we've figured out, we've looked at a lot of avenues, and essentially all of us combined, Mike, myself, Roy, the QA/QI committee, need to kind of tweak things as we get into the first couple of months of the program. Perhaps we need to revisit whether or not we need to switch out our pumps or whatnot. But the 100% QA/QI, trying to figure out what we need to do to make the program better. As far as our next step, and I think Tommy touched on this a little bit before when we were discussing about the SCT, about transports, was that doing SCT transports as well as having a combined MFI program would be hugely beneficial. At this time, we're trying to get we're trying to get started strictly with the SCT. Months down the line, we'd like to start talking to Dr. Glenn and start making queries about possibly opening up to the MFI curriculum as well.
The last question I would have is, you mentioned ventilator training, you're talking about intubated transfers. We still send 3 people on an intubated, even if we have the transport ventilator.
Well, as per our protocols, but also the collateral protocol is an MFI patient requires 2 paramedics in the back. And while there's been some gray area on what exactly constitutes MFI, whether propofol is considered MFI or whatnot, we've established across the board that if they're intubated and they are chemically sedated in any way, it's 2 paramedics, at least in back. One's dedicated solely to the airway and to the vent, and the other one's dedicated to patient care, hemodynamic stability, and then you have your EMT that is your driver as well.
I'm sorry, so I'm just trying to get this together. You guys are going to do SCT transports where you're going to pick up patients who are MFI.
No. When they're not
Or
MFI,
intubated.
they're not paralytics.
They're not paralytics?
No, they're not
Okay.
paralytics.
So you want to be able to do a SCT transport because you are not MFI certified of a patient who is MFI'd?
Not with the paralytics. Propofol is not considered a true MFI.
They're just sedated?
They're sedated. But as far as, I think the spirit of what the protocols were saying was that, MFI requires 2 paramedics because of they're sedated. And I think that for us, we chose to apply equally that even though it's just a propofol, even though there's no evac or sucks pushed, we want that second paramedic in there dedicated solely to the vent. Just like you had said that the intubated patients, even though they're on the vent and the vent does, almost all the work, you still wanted somebody dedicated to that, and that's what we had said too. We want one person monitoring that vent, and that's solely what they're doing, that airway.
We recently had one leave the hospital on BiPAP. By the time they got to Albany Med,
They had been MFI'd, they went down to MFI'd and on the bend, on the side of the thruway. So a lot can happen.
You really need that extra pair of hands.
So what's the pleasure of the REMAC physicians on this program? The REMAC has the ultimate approval or disapproval of these programs, and it's a very new thing in our region, obviously. This is only the third agency that will be utilizing SCT level personnel with a view toward MFI in the future. Do the doctors feel this should proceed as going forward?
I think we maybe have some questions for Dr. Glenn. If they're not approved yet for CenterLearn, and they're using CenterLearn as the main source of education, is there enough data in CenterLearn to cover all the drugs and to cover all the procedures and information that they need versus a formal class that is set up for SCT?
Beth, could you
And strictly
comment
for training for SCT.
on that?
I don't know CenterLearn, I can't.
Oh, okay.
I don't
Dr.
use
Markowitz,
CenterLearn.
as being a critical care paramedic who did go through the Baltimore program, Baltimore does have a 100% recertification through CenterLearn.
Recertification. You've already got your basic knowledge.
Right.
And I'm questioning, because CenterLearn's excellent source of recertification, but you're building on a baseline set of knowledge that already
Correct.
exists. Or reviewing a baseline set of knowledge. I guess that's my concern.
Yeah, it seems to me the question is, for us or for GAVAG, we sort of grew into doing SCT over the years and developed and added protocols, et cetera, et cetera. Now you're talking about a service that it's the chicken or the egg situation, you know. How do you start that, and how does the REMAC determine, you know, what the process is, what the steps are to get that started?
And CenterLearn has been used in the past for 100% for the SCT program. New another agency I was at down in Remo did the same thing, used it online through CenterLearn, combined with the hospital and the respiratory therapy to do all their training online. Of course, they developed their own program. They didn't quite achieve the 96 hours. They decided that they were good to go at about, we completed about 40 hours there of online material. So we chose to go above and beyond and mirror the didactic portion of what we felt to be the gold standard of the training, which was what we looked to the University of Maryland, the University of Baltimore. So there have been agencies before that have used this to do 100% online for SCT, having been one of them that has done that. And I think that essentially the program material, again, also being utilized as 100% research for the University of Baltimore, says quite a bit about the capabilities of the program, what it is. And again, you know, we had to go to Dr. Glenn and prove to Dr. Glenn that this was not like, you know, like a, well, online, you know, like a YouTube, you know, go through and just play it and be done. So we had to go through and prove to him about the abilities for it and the hours that we have invested into it. And then again, we're also using medics that are not, you know, we haven't taken medics who are new. I mean, these are veteran medics as well, many of which who are SCT or MFI in other regions like myself. So it's a matter of credentialing for our own purposes for our agency.
I mean, to me, it seems like all the appropriate checks and balances are there. I mean, asking about, you've already thought about having the third person and 100% CQI. I mean, it really seems like all the checks and balances that to determine if there's problems with any of the personnel are there.
Do you guys have, you have MFI in Cooperstown?
No, we do not. We have a huge geography challenge. I can't get two paramedics within 10 miles of each other. You know, it's just a huge geography challenge.
And right now, even lacking the MFI, for example, right now, our setup, if we have to take somebody out of Latour's to basically take, we'll use, for example, they're on a propofol drip. So as it is right now, we have to take a respiratory therapist along with us who is on a vent. That respiratory therapist is usually the one that drew the short straw, or at the wrong place, the wrong time, to go get in the ambulance. Not a lot of people really want to do that. They like being in the hospital.
You just don't feed them then, right, you know?
So, I mean, well, I'm not there. I mean, who couldn't like me? I mean, but, you know, they will complain when it's me, but, so we have the respiratory therapist with a hospital vent that's unmounted, trying to secure, it's not designed for ambulance transport. And then we have a nurse aboard for a propofol drip, who also presumably drew the short straw to get out of the ambulance, or wanted to escape from the ER. I don't know. But, so we have personnel who are not ambulance oriented, and then another paramedic on board. So we'll use that same scenario that patient's going downhill. Right now, that respiratory therapist does not have MFI capabilities, nor does that nurse. So if the patient starts crashing, it's up to one paramedic in the back to end up doing intubation on the side of the road, and so on. So from what we're at right now, it's a step up in the level of care. It's a service to the patients that we're seeing, to be able to have that capability. We have a transport event that's mounted there. We know it. We're not utilizing the hospital's event, and we have both paramedics in the back that are competent and knowledgeable about the material that they have. While we don't have the MFI, it's no different than when we had the respiratory tech as of right now.
It's quite a bit different than when you have respiratory tech. The respiratory tech is experienced with ventilators and taking care of patients, as is the nurse. That's why they send them. The hospital appreciates it. The hospital doesn't want to send out a respiratory therapist and a nurse, but they also want to send out a patient that's safe in transport. Practical experience is worth a ton. You can learn a ton from a book, but you need, I mean, it kind of sounds to me like it's rushed a little bit. And I think that transporting with someone that's done it before and having something like that and seeing what you need to learn is a very important step in the development of your skills. And you can learn a ton from a book and online or from whatever, but doing and learning are two separate things. And that's why the hospital sends people, and all the hospitals do that, for the patient's safety, because they're sending people that are experienced with problems that can develop.
But true, we were answering the question about the MFI. I was talking to you as far as the MFI portion of it, about MFI not being into play. And my point was just that currently the MFI is not into play as it is, so that in and of itself is not necessarily part of the equation now. That's what I was saying. I wasn't saying anything about the respiratory tech not having the knowledge, and you know, they 100% they do, and the nurse that they do. I'm just saying that my point was strictly in regard to Gary's point about the MFI, about a patient going downhill and having to be chemically paralyzed and intubated on the side of the road. And my point was that right now it's equal across the board. Does that make any sense? What I was.
Some, I don't know. What do you think?
It's been several months that we've been doing it. So it wasn't exactly like we sat somebody in front of a TV, 2 weeks ago and made them watch a bunch of stuff. Again, most of the people have been credentialed in other areas, have their MFI capabilities down at Remo. And
most and all are two different things. It's a big difference. We're not approving a couple. We're approving everybody. So everybody it should be kind of an equal spectrum for people.
Oh, I agree.
Yeah. So I don't know. I have some reservations.
I do too. I say we need to at some point talk with Dr. Glenn and see.
And I don't know, Dr. Glenn's experience with ventilators and intubating and paralyzing people is
Well, Dr. Glenn is not, respiratory therapy is the one that you know, we showed to Dr. Glenn, like, hey, look, for example, all right, who's going to do your ventilator training? You know, we weren't having somebody that, oh yeah, I used that vent 10 years ago. We weren't having somebody like that come in and do the class. For example, it's not, you know, his questions were, what kind of program you have, who's the credentialing, who's the qualifying people that are doing this, and what kind of information are you delivering? And we promised him, told him that we would contact the respiratory therapy department at Latour, and we would talk to them and work with them, and we'd have somebody from respiratory therapy who, like you said, are knowledgeable. They've been doing that. You know, nobody knows a vent better than a respiratory tech. So as far as the person that is able to teach people, that's the one that we want to do it. You know, not Dr. Glenn. I mean, as good as Dr. Glenn is, like you said, he doesn't do vents and sedation meds and what have you. We also have people from LifeNet who have been doing difficult airway classes. Some of them work for us, so it's not. But we've had people who have been experienced flight medics giving difficult airway classes to medics under the supervision of CICs. So we've been progressing, and this has been probably since August.
4 months ago.
About 4 months ago, we've been doing this training. So it wasn't like it was an overnight thing. Now the training over the last 4 months, I mean, they put a lot of time and effort into it. So the program delivery is, yes, a little bit unorthodox, being delivered online, but the program itself, if you were in a classroom, you know, it's what you're getting from that classroom. You can be sitting there texting or zoning out. The classes delivered online are more to the benefit of the person that's taking it, that they can take it on their own time, and it's interactive, so they can't walk away. So it's been proven it's no different than walking to a classroom, sitting down, and getting material delivered to you by a lecturer.
I don't think that's the question. I think the question is experience and physical experience, like ride-alongs. I think that they're very useful. And I don't, unless I'm missing something, I don't see any of that.
Just because this, for example, when respiratory therapy was training some events, they were like, well, here's the number for the on-call respiratory therapist. If anything happens anytime, call. But even though you guys have your 2 paramedics and you have somebody with a vent and whatnot, if there's any question about the safety or you just don't know, they're like, all you have to do is ask, and there's no problem. We'll provide a respiratory therapist to go in the ambulance. They're saying this isn't just because we have the SCT program, all of a sudden now no respiratory techs on the ambulance. So, for example, say we have that patient at the ER from the SCU, and that patient is a pretty intensive patient. I mean, they got a lot of stuff going. Their trach is just, mucus is just coming out from all ends, and they require quite a bit of suctioning. And the paramedics that are there ask, you know what, I'd probably like a respiratory tech to go along. Respiratory therapy is willing to provide those techs to come along with that. And there are those calls that are going to need more people. So this isn't, we're shutting out respiratory therapy at all.
I'm sorry, I was just trying to get a better understanding. You had 10 people take the class?
Yeah, there's 10 people.
How many are already SCT certified?
In other agencies?
Yeah.
Off the top of my head, I can't, roughly half in other agencies. But with that, I don't have that.
But they took all the hours and classes stuff again?
They're MFI'd in other agencies. For example, I have my MFI qualifications from Remo through Moreau Ambulance. We have my SCT. We were doing over at Moreau. We also did it with another agency as well. And there's a couple of people that have that. Everyone works multiple agencies. It's just the name of the game. So they have.
It's the nature of emails.
Yeah, they have the credentials elsewhere, but SCT is purely. It's not like a paramedic card where, you know, it's.
SCT transport can't cross agencies?
The medical director can choose to accept or not accept that. Somebody can come to us and say, you know, you can come and say, I came to the University of Baltimore, critical care transport paramedic program. And you know, Dr. Blank would be like, well, no, I want you to go through our program. So
or he could just sign off on it? Does he have that option?
Or he has the option of signing off on it.
However, you've still got to put them through the equipment training.
Yeah.
I mean, you
The
cannot
equipment
just, you.
The ride-along time.
The ride-along, the equipment training.
It's no different than if you in-serviced a new piece of equipment. I mean, no matter what you have, I don't know what type of vents you use or what type of pumps you use, but chances are they're probably not the same ones that other people use as well. So if you went to another agency, even with a lot of experience, you're going to have to do an in-service on that equipment with the ride time.
Can I make a suggestion? I mean, it sounds like you have a good program, but you already have qualified people. I mean, it seems for the ones who don't have the hands-on experience, there should be a mechanism in place for them to be precepted by those who already have the hands-on qualifications prior to.
There is, but like she was talking about, it's the
I mean, there should be a set number of hours or something in your program to.
And we do that for the continuity of the program, but it's hard to say we need to precept, Mike, I need to precept you before you can jump on and be critical care when there's no critical care program that you have currently that you're precepting in. So we're not looking at jumping out right off the starting gate and going crazy. We're looking at having the capability to do transports, working closely with respiratory therapy from the hospital. This isn't like a, you know, oh, they came and did the classes, we're done. This is a hopefully good working relationship with them, because we want to do people have constant in-services and competency training every several months. So this isn't the end of a relationship. It's more the beginning.
No, I understand that. But I guess to get to Dr. Fisher's point, it seems like if you have people who are certified to do this activity with another organization and are already doing it, they might be the perfect people within your group to provide the preceptorships for the ones who don't have some hands-on direct experience.
And that's the plan to do that. It's,
I mean, so that should be
we
part
have
of your
people,
mechanism.
We have people that are there, and it's not either and all or nothing. So just because somebody is a paramedic just doesn't mean that when you go to that agency they're comfortable with letting you go ride as a paramedic by yourself. You know, they might have you ride as a secondary medic for a while, and so there is that mechanism in place. And you know, Dr. Wen was.
But I guess what I'm getting at is, from REMAC's point of view, maybe it would be. I mean, that might be something we would look for as a criteria for approving.
Yeah. I mean, we are. Again, like I said, we're not under the illusion that we're going to go right out the starting gate with everything. We're looking at getting our feet wet, starting out with the capability of doing it, getting people trained, working with respiratory therapy to do these. You know, even if it's for the first couple, you know, if it's not as strong, if somebody hasn't had years of experience with MFI and whatnot, or even if they haven't had a tube in a while, you know, maybe, you know, having a respiratory tech ride along. So there's plenty of mechanisms in place that this isn't just release and go. It's being watched under a magnifying glass from day one as far as what is being done.
I mean, being watched is great, but being trained is probably better. I mean, you don't want to. You're going to identify. You're going to wait till you hurt someone to identify and then say, "Oh God, did this happen?" That's not what we're talking about. We're talking about having you go with someone that's experienced and seeing the real thing instead of seeing it in the classroom. There's a huge difference.
So who do we go about?
I don't know, but I think someone, or you have other medics, I think that's a great point, is don't allow it out unless there's an experience with an inexperience. You didn't present anything like that, you didn't bring that up. That was far from over there. I think that's...
Well, we did, perhaps I glanced over, I wasn't making it clear. I apologize for that. So we have a core group of medics who have, like I said, who have been from other agencies. I apologize, I don't have the specific numbers because, quite frankly, I wasn't asking, I didn't have that in front of me. So we have a core group that have plenty of experience. Our intention was to designate people primary and secondary. So your primary people are the ones with experience, and your secondary people are the ones, like if you have an event that you need to go along with, they can help out, they can work under somebody. For example, and I hate to bring up other agencies constantly as a example, but like over at Monroe, they have primary, secondary medics. Your secondary medics are your newer people. They're put with a paramedic, and then after a while, when they're shown that they can perform competently, they're released and allowed to work independently. So we're not looking at handing.
I mean, I think that's basically what we're asking for you to put into your program, is to have that as a basis of your training, that you're already prior experienced working people doing this. Like you say, you'd have we would, where the people who've just taken the classroom work and the hands-on in classroom work would have some sort of mechanism to provide for, say, 30 hours or 40 hours of accompanied transport to get actually hands-on experience under the experienced provider.
I mean, as far as the critical care, this isn't something that's being done outside. It's not like we're taking the event to a 911 call to making somebody putting them an event. It's strictly for inter-hospital. And say, for example, at a critical care level, say even somebody, even GAVAC or another agency that has critical care long-standing, and they show up at the ER to take a patient from you, it's the hospital's ultimately responsibility on that patient sending out. So the hospital owns that patient until they get to a receiving facility. So conceivably, somebody could show up who's critical care, and you could watch them playing with the event and be like, well, I'm not really comfortable with you taking this patient, because as a sending physician, are you not in control of that patient all the way through until they get to their destination? You send a patient out from Albany with us or anyone else. Nathan Latour owns that patient until they get to the hospital, correct? So if something happens, we call and talk to you?
No, not necessarily. You call Albany Med and get direction. They're called divert to the nearest hospital, and if there's a problem, you address the problem. You might not be able to get in touch with us. There's not. So.
But it's the setting facility's comfort. If the setting facility is not comfortable with taking the patient out, with that agency taking that patient out, there's no.
We're trying to establish a comfort level. We're not doing a good job of making the physicians. There's two physicians here. Neither of us are comfortable with what's been presented. All right. So, I mean, we're listening to input, but we'd like to be satisfied. Experience, practical experience is important, and that's all we're saying. We're happy with the training day. In 96 hours, it sounds like it's very organized. I went through the papers last night. I thought it was fine, but I don't see any ride-along stuff. I don't see any. Have you been to the hospital with ventilators? I don't know what you've seen on real patients. I know what you've seen in the classroom, but there's a huge difference. They don't just approve us to do things. We do residency, we do training, and there's significant, there's numbers of procedures that we have to do before we get approved to do it.
I agree. Would you, let me ask you a question, would you feel more comfortable if we had in our protocols that that respiratory therapy would ride along during as we get things off the ground, we have respiratory therapy continue to ride along until they are satisfied your level of comfort with that patient, of those calls.
I'd like to point out that the intubated interfacility calls are like 5% of our SCT work.
I'm concerned about,
Which is all the more reason to have at
Yeah.
least some good hands-on
Yeah,
experience in the
and
field.
it's just, you know, we seem to be really focused on the highest acuity patient as well, and I understand why, but in reality, it takes months and months and months and months and months for CMT to clear someone off their internship. They have to do quite a number of intubated, and I called Doc Markowitz and said, listen, can you have anybody that's intubated, make sure you call us, because I got paramedics I need to clear.
yeah.
We're not looking to
Yeah.
approve the weak link, we want to approve the strong
Strong
link,
link,
and the link will come down. Always the worst case scenario.
But I just wanted to point out, it's a
Well,
very,
you're talking-
very small
You're talking about
subset.
intubating patients, but I'm thinking about a lot of drugs. I'm
That's-
thinking about pumps. I'm
that's-
thinking about critically ill patients who are hypotensive on 2 pressors going to a trauma, to a level 1 trauma center.
Exactly, I was just gonna say, we're getting hung up on
I'm,
this respiratory
right,
stuff.
and we can bag, we don't need a ventilator. So, yeah, I'm worried about I've done center learn. How is center learn gonna give you the knowledge of all the drugs, the indications, contraindications, and a guaranteed knowledge base? That's what's spooky to me before I put them in your ambulance.
Yeah.
I'm gonna recommend that this be reviewed a little further before it's approved.
Because you're gonna get a lot of patients with 3 and 4 meds going, and critically ill, or really bad traumas with blood going, or whatever. And
Well, bloods we can't, nobody around here is sediment take.
Not yet,
Not
we're
yet.
working on it.
But-
Yeah.
And we're
But
currently
you
taking
still-
patients that are on the hospital's pumps with no nurses. So the pumps thing is not a huge deal, it's what we're already doing.
Well, it's not the pump so much, it's managing the meds, that's the big deal.
Because right now, as a basic, we're still taking, at a basic level here, we're still taking patients out with heparin drips, with labetalol, all sorts of medications running. As a paramedic, they're saying, here's your patient.
How are you doing that without an SCT program? Are you taking a nurse?
can't.
Because you
We're
can't be.
taking a lot of nurses with
Okay.
certain medications, but and we're also putting the hospital's pump in our truck, which the Braun pump's just attached to the IV pole, but one stop and that IV pole just kind of
Well,
We've done that for decades
We've
and
done
never
that for
had a problem.
decades,
I mean, we still continue to use hospital pumps. It reduces the errors during switchover.
right.
yeah. But again,
So-
we're not looking at doing away with everything 100%. We're saying, there are those cases where, if there's a drug and I'm like, I've never even heard of that drug before. I don't even know what you're talking about. That's not a drug that I'm like, okay, let me Google it. I mean, that's something that you want to take somebody along with you.
You said
So-
sometimes you take a nurse, sometimes you don't?
What's that?
Sometimes you take a nurse, sometimes you don't?
With certain drugs we take it, but like they've been running heparin drips and or nitro drips and taking as a regular ALS.
Both approved, those are both approved by our protocol
Yeah.
currently. Those are ones that, if you look at right now, the current collaborative protocols, the interfacility, those are two of the approved ones that can be done without SCT.
But I mean, even with that, some of our newer medics that even along the collateral protocols, technically, yeah, they can go and take a heparin drip or a nitro drip. I wouldn't feel comfortable as a supervisor sending some people on that call and be like, you can't even tell me what that medication is. You can't even pronounce it or spell it. Probably not. On the transport. So there are cases going to be where we do still take a nurse, we do still take a respiratory therapist. Nothing is we're cutting anything out. We're just looking to add to the capabilities.
And I believe with this protocol switch, heparin and nitro will move to SCT. There will not be any more interfacility designations in the new collaborative protocols. So all of that will have to move, that all moves into the realm of SCT.
What would our REMAC doctors like to see by way of additional protocols for ASFC or additional training?
I'd like to look at Center Learn, and maybe we should discuss it with Dr. Glenn as well as the further education, one-to-one with experienced providers back to the new providers.
That's reasonable.
I'm sorry, I didn't.
I think that's reasonable.
Okay. Okay. Thank you for the presentation. Didn't expect you were going to be the guest of honor here this morning, right?
Well, I had an inkling when I talked to you on the phone.
I have an update on, speaking of protocols, I have an update on the rollout of the collaborative protocols. And I'll repeat this during the AAREMS portion of our day. The collaborative protocols have now been adopted by 15 regions. The only 3 that haven't adopted them, surprise, surprise, New York City,
Nassau
County,
and
Suffolk County. Right, there you
Nassau
go.
and Suffolk,
New York City
yeah.
and Long Island have not adopted them, and I don't believe they're ever going to. That's just my own personal
They
opinion.
have more chance of becoming a code.
But there you go.
He has a lot more chance than we do.
I'd like to see what's going on. That'd be great. The updated protocol app in the Apple format has been sent to Apple for final approval. The Android version should be ready shortly. Training modules are being developed in several different formats. Now, training materials consisting of PowerPoints, videos, and PDF documents will be released on February the 1st, that's a week from next Wednesday, and links to them will be placed on the AAREMS website, so that everybody informed of the links of being available, of course, everybody will be able to hook into the training materials. This is the folks already credentialed in the region I'm talking about. A bank of test items will be ready in each category, AEMT, critical care, and paramedic, by February the 1st. And either a link will be provided for all AAREMS texts or the items will be available on the AAREMS site directly. In either case, a certificate will be electronically provided when the exam is passed. It will remain an open book exam. Central New York and Monroe Livingston are discussing now who's going to have that software available, but they're going to give a link to all of us. Now, our REMAC has the option of deciding against an exam for currently credentialed techs with the training to suffice, and with only new techs to take the exam. REMO has adopted that principle. They're not going to require their presently credentialed techs to take another exam. They're just going to require them to certify in writing that they have taken the training. And this is what I would recommend for our REMAC physicians' consideration. Rather than put everybody through an exam process again, it's an open book exam after all, and it's designed, and this is why we have it for the new text, it's designed to enhance your reading ability of the new protocols, way to look something up in the new protocol. I would recommend that we go with an attestation from the currently credentialed tech that they have taken the training. That's my own personal thought. I bow to the REMAC physician's decision on that.
I'm all for testing.
You're for testing. I think it's fine not to, so.
Okay. He's the boss.
We have successfully rolled out previous versions of protocols with just attestation. I know personally we're doing a huge equipment rollout at the same time, and we'll be touching on the new drug Decadron, things like that, so that there will be some sort of beyond what the regions, beyond what the collaborative teaching is, that agencies do need to do a bit of education on stuff. And I think that the agencies the burden's on the agency to make sure that everybody understands it, not on a test that you go through and multiple guess out of looking at a book.
We have an extraordinarily, what's the word I'm looking for? An extraordinarily honorable group of credentialed techs. We have 292 credentialed techs at all levels in the region, and they are very good about keeping their credentialing up on a yearly basis. They're very good about, and I QI a whole bunch of controlled substance PCRs, and really, they're excellent. They're excellent. Outside of bad handwriting, which we all suffer from to a lesser or greater degree. They're really excellent. So I really think that an attestation, access to the training, an attestation that they've taken the training, I think that would be quite sufficient. I certainly do agree that we should have a credentialing exam for the new techs coming on. There's no question about that. But for the current ones, not so. That's my own thought.
I agree.
Attestation.
I would agree with that too.
Yeah.
It is expected that the Apple and the Android apps will be ready by March the 1st, which will be a soft month for provider training and credentialing, with a provided deadline for credentialing of March the 31st. In other words, the drop-dead date is March the 31st. If you're going to continue as a credential tech in the region under the new collaborative protocols, you got to have your act together by March 31st. In other words, all techs are expected to be ready to practice under the new protocols by March 31st. That's the current. Now, there is a little bit of a finagle factor, if you want to call it that. They don't call it that officially, but there is a little bit of a finagle factor. It all depends on the software people out in California as to whether the Android app is going to be ready. When it is ready, it'll be, I don't think it's going to be automatically downloaded, although they are talking about that. I don't know how that works exactly.
It would be an automatic update to anybody that already has the app, but if you choose to download it, you'd have to seek it out and find it.
Ah, gotcha, okay.
Sir, and they're to write an attestation letter to you at AAREMS?
I'm sorry?
They're to write the attestation letter to you at AAREMS that they have completed the appropriate training?
What I'd like to do is let that happen at the agency level. And honestly, I haven't worked that out. I wanted to present this to the REMAC docs this morning before I work that out. But whichever is the easiest way for it to be done. I kind of think that it might be, just off the top of my head, I kind of think it might be easier to do it at the agency level, the way we're doing the re-credentialing, the yearly re-credentialing right now, which is coming along quite nicely.
I would think that if you had an attestation letter that had each one of the modules that are the electronic modules that are coming out, the videos for, give me 1 second, I have the list of the videos with me.
Okay.
Well, you're getting a list of videos. Will the agency be responsible for sending something to AAREMS saying that they have 100% compliance with the text?
I haven't really thought that through completely, but that's somewhat analogous to what they're doing with the yearly re-credentialing right now. I think that probably is the easier way to do it.
I have the form that we used in 2012.
Oh, okay.
Still.
If you would share
That actually may not have been us, may have been to REMS. They had a letter that you had a list of all your people and that they had successfully completed the rollout.
If you would share that with me
I
later,
will.
I'll see it again.
And the rollout's online,
Yes, a lot of the rollouts online.
so I need to sit behind my person while they watch the slides to make sure that they do it. Wouldn't it be easier just to have them take a test at the end? You know,
I mean, what you're doing, you're working on an honor system.
Exactly.
You're working on an honor system. If they've signed off and said that they've watched the 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 videos, listened to the podcasts, and all of that, and sign off that they've done it, then if something comes up, it's on them.
Actually, we're working on an honor system right now. We start to think about it for credentialing all of our techs. I mean, it is an open book online exam, and where the honor part comes in when we're depending on the individual tech to be the principal one taking that exam, rather than saying, to John Jones and Mary Smith, come on, do this for me and get me signed on. So we are working on a system now, and it seems to be working.
Actually, it's the agency officer who would also be,
The training officer.
yeah, signing off on that.
So our agency officer is a BLS provider is gonna sign off on the ALS providers completing their training?
It's an agency.
Can you go
And I
recertify?
understand that it's an agency issue, but
Can you go to
I think that
recertify?
Delaware County is the only agency that has captains that are BLS providers. You know, with the ALS. I'm not trying to cause a problem, I just wanna make sure that the education gets out there the way it needs to get out there.
Yeah, understood.
Well, if John Jones is a basic EMT, he can sign off that Mary Smith, who's a paramedic, has taken all this training. Whether she has profited from the training is another issue, of course, but you could sign
When it goes to
off that she-
recertify, though, you need to have your medical director sign.
You gotta have your medical, you have to, somebody else sign it, not the BLS provider signing off that you did your training like you were supposed to. I guess that's.
So we have our medical director sign off on the tech cards every
Right.
year. I could see having the medical director signing off on the attestation to the AAREMS as well.
Yeah, that,
That would meet it
Okay.
right there.
Oh, is that,
That sounds good.
does that sound good? Okay.
And then it gets forwarded to you so they stay online.
Okay.
Great.
All right. The next item on the agenda, the Wadsworth Labs request routine biennial approval for continuation of glucometer testing. Dr. Fisher has already signed off on that. And the update on status of AAREMS BLSFR agency recertifications from Mr. Farrell.
Aaron get the gold star, everybody, he's right.
Oh, only one gold star? Gee. Only one gold star?
Well, you get 6, actually.
6, okay, good, excellent.
I'll give you 7.
How about the agency compliance with DOH recertification and/or inspection requests?
That's the 7th one.
That's the 7th gold star, but I have to tell you that, I have to tell you this on Speculator Ambulance. Joe got a hold of me a while back by email and said, time for the Speculator Ambulance inspection before recertification, and I said, okay, we'll arrange a date right after the holidays. And on December 28th, a deer hit our ambulance while we were transporting an unstable patient to the hospital. Bottom line is, thank God, nobody was hurt. We had an excellent driver on board, and he did all the right things.
What about the deer?
The deer was badly hurt. I'm happy to report, let that go for the record. And over $20,000 worth of damage to our nice Chevy ambulance, a 3-year-old ambulance. Yes, it's down in the repair shop in Connecticut, being repaired, and we are dealing with a loaner. Somebody asked me, how do you like your loaner? And I said, well, it's like living in a Gold Star hotel. It's wonderful, but it ain't home, you know? In any event, we had to postpone our inspection of the Speculator ambulance. Unless you want to go down to Connecticut and take a look. It'll be ready in about 2. It's going to take a full 30 days to get it repaired. It took the whole front end right out, something terrible. Like I said, we had a wonderful driver.
It's in the back.
Our tech and our EMT in the back were unbelted, actively caring for an unstable patient with severe pain. And if the driver had swerved at all, there would have been injuries, no question about it. But quite a bit of damage. Those things happen. So there can be legitimate reasons for postponing an inspection.
Had to call a Mayday to Fulton County.
Well, Fulton County
Come
came
get
up-
me, please.
Yes, it happened down in.
It happens more than, you know, I think Lawrence was just out with a deer hit, and we get deer hits fairly regularly with a number of miles.
I think we had 11 deer hits in all of 2016,
Holy smoke.
most of which we fixed out of our parts bin. But
Is that right? Yeah, this guy just hit us right. Just hit us right.
yeah, I think we
We
said.
are putting on a so-called cowcatcher, however, a bumper car. Cowcatcher.
I never got to see the deer.
Wasn't
I would make a call to Fulton County to
You're
get
ready
help
to
to
put a moose
move
catcher
our
on.
patient. And the police came, and he got in the back of the ambulance, and he said, you guys okay? And I said, yeah. And he said, where's the deer? I said, I haven't been out. It's gone, he said. And what do you mean it's gone? I know that we hit it. It's got to be here somewhere. A guy in a house on the side of the road there, right where we were, came out of the house came through the snow, grabbed the deer,
Really?
and there's a blood trail, and he took it home.
It's already in the freezer.
There you go. He said, well, that makes my job easier, you know, because I don't have to write a tag. So we lost the deer and the ambulance.
I didn't think there was that much left of the deer from the,
He let him have it. Nobody wanted it.
Yeah.
Somebody's sausage.
it was,
Put those little things on the front.
Yeah.
oh, I tell you.
Worcester did a beef cow, so
Really? No fooling.
25,000.
25,000?
That's the work, because you don't see them running.
Yeah, 20,000 was the working figure that the dealer gave us.
The beef cow didn't go anywhere.
No, I
It's right-
imagine.
it's right there.
It bounced right off it, yeah. That's something that moves, so you really moves it.
Yeah.
Anyway, these things do happen. 16. That's incredible.
Yeah.
That's incredible. Anyway, the only other item of new business that I have personally, Dr. Leinhardt, well, by the way, in case you came in late, Dr. Leinhardt had a motor vehicle accident this morning on the way here. He called up to say, I don't think he hit a deer, no. I don't know what he hit, but he was waiting for the tow truck. He said that he was fine, his vehicle wasn't, and he wasn't going to be able to make it, and he was very sorry. In any event, he had asked me to put together a program, a report off the state bridge data, the electronic PCR data, showing destination data for several of the larger providers in our region. And I made a start on that, and in fact, we'll have a conference call tomorrow with Mike Taylor at DOH about that. I whipped together a report for him, for Dr. Leinhardt, which I will send to him electronically since he's not here. But it's going to be a very interesting report. It's going to have a lot of information in it. He's interested in seeing how often ambulances bypass their nearest hospital to go to another one, and if we can determine the reasons for that. Don't know what the genesis of that was, his request was, but we're working on it in any event. That's my report. And if there is any other old or new business to be brought,
Yeah, I have an item, Phil.
certainly.
At the State Council last week, we were asked to bring to the attention of the REMACs the fact that there are a number of services, ALS services, who have not yet applied for a controlled substance license. About in the middle of the packet that I handed out is a copy of the letter that went out from Lee Burns to these agencies. And then there's a couple of pages of lists of agencies, ALS agencies, who have not yet applied for a controlled substance license. They have until February 1st. So the point of what I want to bring to the REMAC is that there may be some agencies at the next REMAC meeting who need to be deleted from the list of ALS agencies. I made some little tick marks to the left of services that I believe are in our region. I counted up 11. Some of them may have applied already. Joe may be able to update some better information about that. As of last week at the council meeting, 53 agencies remained out of this list who had not yet applied for a controlled substance license. In the letter, of course, is the Part 800 edition, 800.5, where it makes it clear if you want to be an ALS agency, you need to be able to use controlled substances. So I just want to bring that to the attention of the REMAC, just to give them a heads up. Joe, anything?
Yeah, well, there's a couple that applied. Bloomfield is one of them. Grand Gorge is in the process of doing it now.
Oh, good, okay.
It's your contracts.
The town of Pittsfield is basically a muni that's gonna go under,
Right.
their
Contracts.
contracted agency, so they don't really need a license. And the rest of them, I haven't heard from
Okay.
yet. They need to, it was very specific in this form, they need to have at least a working copy in our office for approval by February 1st, otherwise they have to drop that.
So, you know, a word to the wise would be usually sufficient. But that was all I wanted to say.
Thank you, Mark. Several weeks ago, I can't give the exact date, but Mary Ramos sent me a listing, kind of a working listing of, probably the same one. And I did reach out to the agencies on that list at the time. There were a couple of agencies that were in process of developing their controlled substance stuff, and I advised her of that. And since then, I've heard nothing further except for health report.
And there's no wiggle room on it. It's February 1st. It either has to have the application in process in my office or never.
So that's it. Is there any other old or new business to be brought before the REMAC?
I have a question for Joe. Is the letter going out to these agencies?
They've already been
Regarding the deadline?
Everybody should have gotten the letter.
They should have gotten this letter.
Okay.
And there is no wiggle room. February 1st, if you not at least have the application in our office for review. If it's in our office for review, you're fine. There's nothing in the office, we have to notify.
Postmark
That's
by?
it.
You did.
Sorry?
Postmarked by February 1st?
Yeah.
It's got to be in my office, by February. Sitting on my desk. It may take a week or two to review it. It may take 4 or 5 weeks to get the license, but if it's on my desk by February 1st, you're fine. If it's not, you have to drop down to the 4 or 8 years.
I think it's worth a further comment that any agency that is not going to apply for controlled substances will either have to become a BLS agency or an AEMT agency. Those are the options. So you need to be aware of that.
Do we have anything further?
And I'm sorry, any ALS drugs that you have, there'll have to be some surrender mechanism for all those drugs.
Mark, that's automatic, a drop down, correct? Or do they have to actually apply for it?
I think they have to work with their.
Automatically drop down to BLS, you have to go to REMAC for AEMT.
Yeah.
Okay.
Right.
Okay.
So Phil, should you provide those agencies with a phone call just to let them know that this is serious?
God bless them, we've been calling them and we've been emailing them, and that's why there's a drop dead date of February 1st. This is not new, this has been going on for months and months and months. Everybody knew it was coming. It's been official for a long time, and we've contacted all of these agencies in one form or another, and Bloomfield is working on it, Grand Gorge is working on it, a few others. The rest of them haven't done it.
Right. I will be glad to send another email out to them.
Yeah, I appreciate it.
I already have done so, but I'll be glad to send another one out.
Yeah, I would do it, because I've been calling them too, but half the time I don't get an answer. So.
Most of the time, I don't get an answer.
So just informational, Amsterdam Fire Department has been approved by DOH and our medical director to utilize Center Learn for up to 100% online training for continuing ed.
Okay.
Sorry, sir, what, you got approved by the state, or you?
Yes. Approved by the state like a week and a half ago, start for contract signed with them, and everything was approved and submitted to G. Myers.
Anything else to be brought before the REMAC doctors? Dr. Fisher?
Close.
Okay.
We're done.
Adjourn? 11:52.